kidney function to mature quickly, and then that's what enables potty training to occur. You have to wait that length of time to allow the kidneys to kind of catch up with the rest of the body. Our elderly go the opposite direction. They have even lower amount of water content, usually somewhere between 45 and 55%, which doesn't sound like a big drop. 5 to 10% drop doesn't sound like a large amount, but they also have some other things that are problematic for us as we get older. One, they don't have as much sub-Q tissue. You know, their skin tends to hang. They lose muscle mass also. So one of the things we also know in our elderly, remember, is that they lose that thirst reflex. So they don't respond as quickly to thirst as we would as adults. Most often what we do is, in the age range of, say, our 20s to our 50s or 60s, is we tend to ignore the thirst reflex sometimes because it's not convenient to drink water. But the elderly just really don't realize they're thirsty. So they become dehydrated more quickly because of that fact. They just don't respond. Also, we know that men have a greater water content than women, mainly because men have a larger muscle mass, which tends to hold a little bit more water. Women, unfortunately, we tend to have a little bit more fat, which is essentially water-free. And so that makes the difference also when we're treating our patients as well, because of that change and shift between muscle and fat and the amount of water that we can hold within our body systems. We have 3 fluid compartments we're going to talk about. The first one is the intracellular fluid compartment. And intracellular is just that. It is the fluid within the cell. So it is the fluid within the cell, and its abbreviation is ICF. So as we go throughout the day, you're going to learn some more abbreviations to utilize in your notes. But we sure don't want to keep writing intracellular and extracellular. That would get old after a while. So use the ICF. This accounts for 2/3 of the body's water content. So it is a large amount. What you must realize is all these compartments are separated by what's called a semi-permeable membrane. Semi-permeable membrane. And that membrane allows things to go in and out of the cell. And so some cells are pickier about what they will let in and out. Some particles are larger and can't move in and out. And so that's why you need at least a semi-permeable membrane to at least move the fluid around. And we're going to talk later about fluid shifts and how things happen on that level. But intracellular is within the cell itself. Then you have extracellular fluid, or ECF. This is the other third of the body's water content, and it is the fluid between or around the cells.
Greetings, sir, and
it is composed of the fluid that's within the interstitial tissue areas and also within the vascular areas. So this accounts for the amount of fluid that's circulating in our blood vessels. So intracellular within, extracellular without, or outside the cell itself. And then last but not least is one other little area called the transvascular fluid compartment. This is usually only about 1 liter of fluid, so there's not a lot of fluid here. But what's important about this is where it's located.
Sleep with one eye open.
This portion of the fluid is in areas that have very minute amounts of fluid within them. So if you think of cerebral spinal fluid, there's not a lot of fluid there, but there is a small amount of fluid in that area. Also within our joints, the synovial joints, we have a small amount of fluid. The reason I bring up this particular area is when we talk about fluid shifts and fluid moving into other areas where it's usually not seen, we talk about this transvascular fluid compartment. If you think of someone who has a pleural effusion, who has fluid that's trapped within their chest wall, that's an area that usually has only a small amount of fluid. So that's kind of what we're containing here in this 1 liter of fluid.
Hey there.
And remember I said that with some pleural effusions you can drain up to an exact liter, if not 2 liters of fluid. So that's why I really wanted to bring this up, because these are the areas we worry about that fluid kind of seeping into when we're in some type of overload. So intracellular within, extracellular without or around, and then transvascular is where small or minute amounts of water are normally found. This is just a basic definition. It's not on your note guide. It's just something I wanted you to realize that they have a title for, and that's effective circulating volume. And what that means is your body makes changes within intracellular, extracellular, and the transvascular fluid compartments based on what it perceives as the effective circulating volume. So if it sees that the cells are dehydrated, it will shift fluid to them. If it sees that you need more fluid in your plasma compartment, it's going to shift fluid there. So our body's really good about shifting as it needs to without us even realizing it. So again, this is just one basic definition: effective circulating volume. Now let's talk about the fluid spaces. We've talked about specific cellular and extracellular. Now let's talk about spacing and how that fluid shifts from area to area. First you have first spacing. First spacing is that normal shift between intracellular and extracellular. It is a normal shift between those two compartments to maintain that homeostasis. Body shifts the fluid around as it needs it. Second spacing is where you have fluid that is retained in the interstitial tissue areas.
Hello.
And usually one of the big signs of that is edema, like dependent edema. It's in the lower extremities. And that's just one example of that. So first spacing is normal shifting in and out between intracellular and extracellular. Second spacing is where that fluid gets shifted and it remains out in the interstitial tissue area. And then last but not least, we have third spacing. And third spacing goes back to that transvascular fluid compartment. Third spacing is where fluid is shifted into areas where there's normally little or no fluid. So shifting a fluid into areas where you usually only see either no fluid or very little fluid. The big concern about third spacing is, one, of course, it's fluid where it's not normally found, which creates its own set of problems. But also, this fluid that's being retained in the third spaces is fluid that's not circulating. So that means that the effective circulating volume is decreased. So you may have a patient who has all this fluid, has edema and swelling in different areas, and you wonder why they're adjusting their fluid intake. And sometimes it's they decrease or restrict the fluid intake, and others they're increasing fluid because that fluid is left out there in those third spaces. It can't get back in to the circulating volume. It's stuck out there, literally. And so the only way that we can remove fluid from third spacing, for the most part, is to go in and aspirate it out with a needle and syringe. So in other words, it's fluid that just gets wasted. It's stuck out there in these third spaces. Some of the major areas that you see fluid collect is, again, like the pleural effusion, the fluid within the chest wall cavity between those pleural linings. You may also see a pericardial effusion.
Beware.
Where you see fluid build up around the heart.
Beware.
Again, though, one thing to remember is that when you have third spacing, that fluid is essentially wasted. spacing, it cannot be pulled back into the effective circulating volume. So it's just sitting out there. And generally, like I said, the only way that we can remove it is to go in.
Beware.
Problems, or people who have problems with third spacing, the big candidates,
Beware.
they tend to have a lot of third spacing, especially
Beware.
if their cancer metastasizes in other areas. You start seeing fluid buildup. And again, we're not talking necessarily small amounts of third spacing. I have seen where they pulled 1 liter or 2 liters at a time out of a pleural effusion. So you can imagine the problems that occur because of that. One, it decreases the circulating volume, but
Beware.
two, it decreases their respiratory activity, so it causes even more problems. So fluid is a
Beware.
good thing as long as it stays where it's supposed to be. Then we have electrolytes that are flowing in and out of the cells in the plasma. And these electrolytes are substances that dissociate or split into specific ions when they're placed in water. So if you think, once we ingest certain things, especially we tend to think of potassium and sodium, those are our electrolytes. And once those are ingested, they're metabolized by the body so that it can utilize it. And then they're pushed in and out of the cells or the plasma depending on where the body needs them the most. It's important to remember that they conduct electricity. So we're going to talk about positives and negatives with this next slide. But it's important to remember electrolytes do conduct electricity. We have positively charged ions or cation ions. Those specific ones, the big ones are sodium and potassium. We also have calcium and magnesium. And I would again encourage you to use the abbreviations so you're not spelling them out because we're going to be talking about these a lot. The negatively charged ones are anions, and those are your chloride, bicarb, which is HCO3, so just put bicarb in parentheses because that's how I'll introduce it to you. So HCO3 is bicarb, and PO4 or phosphorus. Now it's important to remember that you have positive and negatives. They shift in and out of the cell to maintain equality between those two areas or fluid compartments. And so your body's going to shift these around as it needs to maintain that neutrality. All of these ions are within the cell and outside the cell. But I want you to know some of the primary locations that you will find them in the greatest amount. So for those that are in the intracellular fluid compartment, the biggie there, or the primary cation, is potassium, which is your K. K is potassium. You also have smaller amounts of sodium and magnesium, but potassium is the big one. When we're talking about intracellular, that means within the cell. The primary anion, or negatively charged ion, within the intracellular fluid is phosphorus, or PO4. Within the extracellular fluid compartment, it kind of swaps out. Sodium is the big one in the extracellular fluid compartment. It is the primary cation. You also have little bits of potassium, calcium, and magnesium. And then the primary anion is chloride. One way you really see the differences in these is if you look, when we draw blood from a patient, and we want to get an electrolyte panel on that patient, if you look at the lab values, those lab values tell you essentially where the biggest amounts of those ions are contained. If you look at the sodium, the normal range for sodium is 135 to 145. The normal potassium is 3.5 to 4.5. So that tells you automatically that sodium is found in larger amounts in the extracellular fluid compartment, and most of your potassium is in the intracellular fluid compartment. So So that's why when we talk about electrolytes a little bit further on, when we start talking about small, minute changes in potassium, that's why you see their effects are greater than small shifts, say, in sodium, because of the different amounts that are contained within the circulating blood volume.
I don't know if this is super important right now, but will you say again which ones were the primary positives and negatives for each?
Primary cation for intracellular is potassium. Primary cation for extracellular is sodium. Primary anion for intracellular is phosphorus. And then primary anion for extracellular is chloride. Let's talk about how these things move around. Remember, we have fluid, we have nutrients, we have electrolytes, we have so many different things that are circulating within our body that are shifting in and out of cells and in and out of the plasma. And there's several routes that it's able to do this. One of those routes is diffusion. Diffusion is where you take molecules from an area of high concentration, where there are lots of particles, to an area of low concentration, or a small amount of particles. So from high to low. Kind of makes sense. If you've got too much on one side of that membrane, you want to equal it out, you're going to shift it to where there's not as many of those particles. You do need a fully permeable membrane, because you may need to shift several things, not just one particle or another. You may have to shift several things. No energy is required for diffusion. That flow from high to low is one of easy transition. The flow between those two compartments stops when there's an equal amount of particles on both sides of the membrane. So it stops when it's equalized. One of the easy examples to understand is when our body exchanges oxygen and carbon dioxide. It's shifting. It's shifting oxygen from an area of high concentration to an area of low, and then shifting the CO2 the opposite direction to swap them out within our body systems. The next one is facilitated diffusion. And with facilitated diffusion, you still are going from high to low, but you need a carrier. You need some type of assistance. One good example of facilitated diffusion is where you need insulin to get glucose into the cell. You need both of those together to get it into the cell. And so that is just one real, very simple means to example that. Active transport requires energy. So that's the big one there. It requires energy. The facilitated diffusion requires a carrier. Active transport requires energy. Because active transport, you're going against that concentration barrier. On this one, you're going from areas of low to areas of high concentration. You're going kind of opposite of the others that we talked about. One of the things here just to remember is in this, you have to think of like the salmon, they swim upstream against the current. That's what's happening with active transport. One good example of that is when you have the sodium-potassium pump that's working and you're swapping sodium and potassium in and out of the cell. It does require energy, and you're changing that, the difference between going from high to low, you're swapping it out, and you're going from areas of low concentration to high concentration. So active transport is the only one that kind of goes against the grain of the others. Osmosis. We talked about diffusion, and one thing to realize is diffusion deals with particles. Osmosis deals with water. You're moving water between two compartments from an area that has more fluid to an area that has less fluid. Okay, so from one compartment that's dilute to the one that is less dilute. What you want to do is you want to equalize the water on each side. So you've got it really high over here, you've got it low here, and you're going to let that fluid move until they're equaled out. This only requires a semi-permeable membrane because all you're allowing through that membrane is water. When we talk about osmosis, we are not talking about anything other than water movement. So it's really important. Students tend to get osmosis and diffusion confused. But if you can always remember, diffusion has to do with particles. Osmosis has to do with water. We have several pressures that help us move fluid around. One of the first ones we talk about is osmotic pressure. And you will see several different abbreviations for milliosmoles or kilogram or milliosmoles per liter. They're both interchangeable. It will not be a test question that trips you up as to which one is which. You can see either one. And what this is the force that must be generated to move water or fluid from an area of low concentration to an area of high concentration. This is the pressure that's required to go against the normal pressure gradients. So you're fighting to get fluid into a compartment that already has some fluid. And we're going to talk about several different types of pressure. There's multiple ones in the board that you will really need to concentrate into your head. I want you to get some basic definitions about this. Colloids are large particles. Big ones that we usually see are proteins. And these are specific particles that are unable to be dissolved in a solution. They maintain their integrity. You can't shrink them. Colloids or proteins are normally found in the plasma or circulating blood body. That's usually where they're at. If you think of blood, you think of proteins, large blood vessels, blood cells within the blood vessels themselves. Usually these cannot escape unless there's some type of injury to that blood vessel. So they're generally contained within the blood vessel. Because their large size just doesn't allow them to move from compartment to compartment very easily. And generally if they're going to do anything as far as moving somewhere else, they're going to injury to that blood vessel. They create what's called colloid osmotic or oncotic pressure. And what they do is they exhibit a force that pulls water to them. So wherever these colloids are, water will come soon. They just pull. It's almost like a water magnet. So wherever those colloids go, that fluid will also end up. The very important thing that the colloids do is they maintain that circulating volume because they continue to pull fluid to the blood vessels. So that's why they have a very important role for staying in the blood vessels, because if they escape, guess what? That fluid's going to escape with them. So it's really important that those proteins, large blood cells, stay within the blood vessels so we can maintain effective circulating volume. Two basic definitions. One is an osmole. And what an osmole is the basic definition is the number of osmotically active particles in a solution. Sounds really fancy. But what that tells you is the ability of that solution to pull to it or push away based on the active particles that are within it. So its ability to either pull or push away fluid or particles, any of those substances, based on the fact that it's osmotically active. In other words, it can generate a force. You have osmolarity and osmolality. And what I don't want you to do is get the two confused. What we usually will see is the milliosmoles per liter. But essentially these are the same thing. They just use two different big words. So try not to get these two confused, because one is based on volume of water, and that is osmolarity. It's milliosmoles per liter The liter tells you that this is the number of osmotically active particles per volume. So this is a volume study.
I know it's got osmolarity twice.
We'll change one to osmolality.
Is it the top one?
Mm-hmm. We'll change. We're going to go. The next slide has osmolality. So osmolarity with the R is the volume. It's based on volume. So that's milliosmoles per liter. And then osmolality is per weight. So it's milliosmoles per kilogram of water. So that's the basic difference. And one is a liter and one is per kilogram. They both are a measurement of the pulling power of a solution. In the definition between the two, as long as you see what milliosmoles per liter or milliosmoles per kilogram, that's going to give you the information that you need to answer the question. Are we through with that? Do we have this? You will also hear terms such as tonicity or concentration. It's just an add-in for osmolality. Because you may see within the physician's notes, they might write concentration. You may see terms like tonicity, or you may see osmolality. They're generally all the same thing. They're talking about the ability of a solution to pull fluid to it or push fluid away from it. It's important to realize that that ability is influenced by the amount of the solution itself and the amount of solutes or particles that are contained within it. So that tonicity or concentration can change based on those two simple things, the amount of fluid or solution that you have available and the number of particles or solutes that you have within that. And this is where it will make a little bit of sense to you, a little bit more sense than just talking all those great and wonderful big words. When we talk about plasma osmolality, a lot of times you won't see this as an order or lab order. But one thing I want you to realize is when you see these particular problems that are going on within your patient's condition, you may see the difference in the plasma osmolality. Whether it's documented or not, it may help you pick up on some problems that they're having. Normal plasma osmolality is between 275 and 295.
I need to target something first.
And that's milliosmoles per kilogram. If it is over 295, so if it's an increased value, that means that there's more particles and less water. In that instance, you have what is considered a water deficit. So if it's over 295, that is considered a water deficit. In other words, the solution is more concentrated. And because of that, if you think of the patient who has dehydration, their fluid volume is going to be more concentrated because there's just not as much of it as there normally would be. In that instance, when it's over 295, the cells will actually shrink. Because remember, the body is a wonderful thing. It can figure out that it doesn't have enough water. And when it sees that, if it sees that there's not enough water or fluid in the circulating volume, it's going to pull fluid from wherever it can. And one of those places it can pull from is the cells. So if somebody's dehydrated, they may have a circulating volume that's remaining at a stable level, but their cells are becoming more and more dehydrated to make up for that. The opposite occurs if it's less than 275. If it's less than 275, it's generally where you have water excess because it's less concentrated, means that there's more water and less particles. So this is the water excess. At this point in time, you may see the cells swell.
Stop by any
or
time.
enlarge to hold some of this extra fluid that may be circulating. And this is just basically to cover just one topic, and that's filtration. You don't really have to write a lot of notes about this. Just understand that the body is going to pull fluid in and out of different compartments based on where it needs that fluid the most. What it tries to do is maintain equality between those compartments. And based on where that fluid may shift, know that it requires a force to shift it. There's some kind of power behind it that will help move that fluid back and forth to where it is needed. And it does this either by pushing it out or pulling it in, based on the different pressures that we're going to talk about. One thing to realize, the rate of this movement, rate of solute movement, I'm sorry, I do not know how to get rid of that upper bar. We'll just have to live with that today. The rate of solute movement is based on concentration or pressure gradients. Remember that high to low? So that's going to affect whether that fluid or particle moves from side to side. Also, the size of the particle may have some effect as well. The type of membrane, is it fully permeable or only semi-permeable? The electrical charge of the particles. And then also the temperature of the body. So depending on whether the body gets hot or cold, it may shift some fluid as well. You may have to speed up that movement. So in other words, there are several things that determine whether or not we're able to shift fluid and whether we can shift particles. The amazing thing is our body does this all on its own accord, without any input from us. So this is all involuntary. It just does it on its own. Blood pressure. We're going to talk about this and then we're going to take a little break.
Can you go back one slide?
I can.
I'm sorry. I've lost quality of
You may just have to flip over and put it on the back of the sheet. You may just have to flip it over on the back. All right. Let's just continue on, and we'll come back and let you go through that at break. Hydrostatic pressure, or HP, not Hewlett-Packard. You're going to see the HP abbreviation several times today. Hydrostatic pressure is the force of fluids pressing outward against a blood vessel, which causes the fluid to escape that vessel. So hydrostatic pressure is responsible for moving fluid from within a vessel or blood vessel to outside the blood vessel. In other words, that's how fluid eventually gets to the cells. It flows out of the blood vessels, hits the interstitial area, and then it will go to the actual cells where it's needed. So the hydrostatic pressure is the actual force that moves that fluid. So if you think of a balloon, if you held onto the balloon long enough and you poked tiny little holes in it, if you applied pressure to that balloon, eventually the force that you're making is going to push that fluid out. That's the same force that hydrostatic pressure is. It's within the blood vessel. So it helps to move that fluid outside the blood vessel. The amount or the force of the hydrostatic pressure depends on the heart's ability to pump the blood adequately out to the peripheral areas.
I have done as you asked, and now beseech you for your blessing.
So you may see a greater hydrostatic pressure centrally, and then as you get out to the periphery, you start to see a slight decline in that because it's further from the heart. So you won't have quite as much of a pressure gradient in your feet as you would, say, in your shoulder or your arm, just because of the nearness to the heart. Again, what this does, hydrostatic pressure allows fluid to be moved out of the vascular volume, the blood vessels, out into the tissues.
I am yours to command.
And it's not just water that it moves, but if you think also in the terms of nutrients. Nutrients are circulated through our blood vessels, and they must escape the blood vessel to get to the cellular level where they may be needed. And so hydrostatic pressure ensures that those nutrients escape. In other words, they escape the blood vessels to get out into the interstitial tissue areas.
The might of the Lich King.
Okay, I tell you what, on that note, we're going to take a break. Okay, let's talk about 4 basic pressures that move fluid, nutrients, and waste products in and out of the fluid. fluid, the interstitial areas, and then the cellular areas. The big one that we talk about is capillary hydrostatic pressure, or CHP, or you may hear it called CHIP. Capillary hydrostatic pressure is one of the greatest pressures as far as pushing fluid and nutrients out of the blood vessel. So pushing it out of the blood vessel. Plasma oncotic pressure does the exact opposite. Remember, oncotic, so this means it has something to do with those plasma proteins. And this pressure pulls fluid and waste back into the blood vessel. So the chip pushes it out, the pop pulls it back in. Whatever.
Pop this back in.
Yeah. Sorry. I've learned that it's easiest to go with the simple statement. We're talking about this pressure. Alright, two more that we need to talk about are the interstitial pressures. Now, it's really important to remember that the interstitial pressures are very minute. There's not a lot of heavy-duty fluid and waste and nutrient movement caused by these two pressures. The big ones are the CHP and the POP. Those are the two big ones as far as pushing fluid out and pulling it back into the blood vessel. But interstitial hydrostatic pressure pushes water into the capillary or out of the interstitial tissue. So if you can get that hydrostatic pressure is pushing away from something, you can get that in your mind, and then the oncotic pressure is pulling fluid to it. That sometimes is an easier way to remember things. Interstitial oncotic pressure is helping to pull fluid out of the capillary into the interstitial area. So interstitial hydrostatic pressure pushes it out of the interstitial area into the capillary, and then the interstitial oncotic pressure does the exact opposite. If you remember from anatomy, a capillary has two ends. There's an arterial end and a venial end, or an arterial or venous end, if you wanted to characterize it as that. It's really important to remember that these pressures differ depending on which end of the capillary you're talking about. Because, of course, you want certain things to happen on the arterial end that you don't want to happen on the venous, and vice versa. But on the arterial end of the capillary, you really want to take fluid and nutrients and push them out of the blood vessel so that it can reach the interstitial and the cellular tissue areas. So at that point, the capillary hydrostatic pressure is greater than the plasma oncotic pressure. So the chip is greater than the pop. This is on the arterial end. And again, if you understand what CHP is, then you realize that's exactly what you want to happen on the arterial end. You want fluid and nutrients to be pushed out of the blood vessel. Because that's where your oxygenated blood is coming from, is from that arterial end. So if you think of oxygen, you want that pushed out. Then, of course, when you flip and go to the opposite end, and you go to the venous end, or the venial end, those pressures change. You still have pressures. You still have capillary hydrostatic pressure. You still have pop on either end of that capillary, but one is just greater on one end than the other. On the venial end of the capillary, of course, at that end, you want to pull fluid and waste products back to the blood vessel. And so that means that the plasma oncotic pressure is greater at that point in time than the chip, or the capillary hydrostatic pressure. Can you see now why you need to get used to chip and pop? Okay? So by the time you say all those words, you've lost your thought.
So it's basically, when you take the arterial end, you want to push out some of the tissues to get the nutrients.
Right.
And then at the other end, you're pulling the waste back in.
Exactly. So on the arterial end, you're pushing nutrients and fluid out. And on the venial end, you're pulling it back in. That's right. Simple makes it easy. Okay, we're going to pause this for a minute, and then we're going to draw. All right, now let's talk about abnormal fluid shifts. We talked about what was normal and what chip and pop were supposed to be doing. Now we're going to talk about things that go wrong with the system. Okay? The first one we're going to talk about is the plasma to interstitial fluid shift. Plasma to interstitial. So that means that fluid is going from the blood vessels out to the interstitial, out to the cells. You can have this if you have something that causes an increase in chip, an increase of that forceful pushing of the fluid out, anything that would decrease the pop or plasma oncotic pressure, and then you may see it also if you have great increases in interstitial oncotic pressure. So now we're going to talk about the specifics about what causes each one of these changes. With the chip, or the capillary hydrostatic pressure, it's increased generally due with plain old fluid overload. Most of these have to do with overload. Whether it's congestive heart failure, or CHF, which is just that, is congestion. There's too much fluid circulating in the body. Liver failure can also cause changes in the capillary hydrostatic pressure. A DVT, a deep venous thrombosis, and then venous insufficiency may also cause some problems. So mainly the chip is a problem with fluid. There's too much fluid and it's got to escape somewhere, so that force is increased. Because there's more fluid, there's more force. So fluid escapes out into the interstitial tissue areas. The pop, or plasma oncotic pressure, can be decreased primarily with anything that lowers protein levels. Because remember, we said that a big portion of that plasma oncotic pressure is the force that's exerted from those large particles like proteins. Okay? So that's why those proteins are trapped within the blood vessel for a very good reason. But if you have someone who is very malnourished, one of the first things that we see in those patients is low protein levels. So we know that that could cause some shifting. We also know liver disease causes problems with the protein, the way it's metabolized and taken up by the body. And then nephrotic syndrome also is through the kidneys. So we may have some problems with the protein as it's eliminated out through the kidneys. The IOP, generally this is not the huge problem with the IOP, except if you have a patient who has large burns. Because remember, when you have damage to that blood vessel, guess what escapes? Those plasma proteins. And they're stuck out there in the interstitial tissue area, so they increase that interstitial tissue's ability to pull fluid to it.
Worm core. Attack!
So this is in definite reference to, say, a burn victim where there's actually been destruction to the blood vessels. It's allowed that fluid to
Advance
escape
to the front.
and be
Twilight's
pulled into
hammer
the
is
interstitial
retreating.
areas.
The temple is ours. Fortify your positions within.
Let's talk about the other shift, and then we're going to draw. Okay? So the other way is, of course, the exact opposite. When you have a pulling of fluid from the interstitial to the plasma, so you're pulling it from outside the blood vessels to inside the blood vessels. We don't see this a whole lot, and generally it's because we as medical professionals have done something to that patient, given them a medication that's causing this shift of fluid. One of the big reasons is if you have an increase in plasma oncotic pressure. That's one of the primary reasons that you will see this change or shift. This is usually in relation to some type of decrease in effective circulating volume. Somebody shut that down. So something has caused a decrease in effective circulating volume. And so the body responds to that by pulling in fluid from wherever it can find it. So if we have someone who has hyponatremia, that may cause that shift to compensate for the hyponatremia. Also, if we use TED hose, you've ever seen TED hose? They're the really thick pantyhose that are hard to get on the patients. Use lots of baby powder. Pretty much any other tricks of the trade that you might use. The biggies, though, that cause this shift that we do as professionals when we're providing medical care is we may give them certain medications. One of the big ones is we may give them colloid medications. And those actually increase the pressure, the pops, because they're plasma proteins or colloids. So they're pulling it in. Things like mannitol and dextran are considered, quote, our big guns for someone who has a severe volume depletion. So something has caused a severe decrease in circulating volume, and we're giving them this. So what that does is that pulls fluid out of the interstitial area into the blood vessels. So it's dehydrating the intracellular to expand the extracellular fluid. Another big reason that you will see this shift is if you have someone who's in hypovolemic shock, because they don't have a lot of circulating volume, the body automatically reacts to that by vasoconstricting. So it wants to hold on to as much of the fluid as it can. It vasoconstricts, and it increases the pressure so that it can pull fluid back into the blood vessels. Because let's face it, if you have low volume, if you're in hypovolemic shock, you're not necessarily worried so much about your toes as you are worried about your brain, your heart, your lungs. And the body knows that. So it automatically compensates when it sees a low volume. It causes this shift. Yes. Okay, let's talk about something that's a little bit more concrete. Let's talk about intake and output. Intake, generally, we tend to tell our patients that they need to drink at least 2,000 to 2,500 milliliters per day. We also need to tell that to our students, our teachers, our family, and friends.
Not necessarily.
Because most often, that's the one thing we forget to do is drink throughout the day. It's very important for our body to maintain that homeostasis, to have enough fluid to do so. Another way that we bring in fluid to the body is also through basic eating of food. A lot of times we'll get in upwards of 700 milliliters of fluid just from our food. Some food has more fluid content, like fruits tend to have a little bit more fluid content than, say, meat.
I sense danger.
Also, just breathing air in and out. Just with that, we can accrue somewhere between 200 to 300 cc's just with oxidation, just with breathing in and out the air.
We must have faith in our allies.
Then I will open the way.
When you're
into the
breathing
eye of
in, you're going to
eternity.
breathe some fluid in just because the air may be moist. There is moisture in the air. And then also we'll talk about insensible loss in just a minute because you're also losing a little fluid when you exhale. Okay. Generally, again, we want to have our patients take in somewhere around 2,000 cc's a day. You may see upwards of 3,000 cc's depending on how dehydrated they are. One thing to caution you, though, is that some of our patients' kidneys don't function very well, and those that are having problems with renal insufficiency generally are on fluid restrictions of some sort. So we can't just barge right in and have everybody across the board drink in all this fluid, because it might just not work so well if we do so. Output is generally somewhere between 2 to 2,500 cc's per day. What I want you to understand is just because you take in all this fluid does not mean that your output is going to be equal to the amount that you took in. When we say you have a balanced intake and output, we have to remember that you have some losses that we can't measure. And those are what we consider insensible loss. Okay? An insensible loss is a measure of the fluid that we can't actually go and measure. We can't take out our graduated cylinder and measure it. So the general rule of thumb for measuring output is urinary output. That's about all that we can measure. And generally, urinary output is somewhere between 1,000 to 1,500 a day. And remember, we said intake was between 2,000 and 2,500. So you're losing somewhere close to 1,000 cc's of fluid in another way besides urinary output.
Excellent.
In
We
some
will
of those
begin the
ways,
ritual
we
at
tend to
once.
lose around 400 cc's out through our skin,
The ritual
just by
will
sweating
take
and daily
much
secretions.
as it
Through our
requires
lungs
a
with
very
breathing,
peaceful
we may lose somewhere between 400 and 500 cc's. Fecal material tends to excrete somewhere around 100 cc's of fluid. So these are small amounts. But you can see if someone had a severe fever and that fever broke and they were sweating it off, they could be losing a lot of fluid that we couldn't measure. The same way, too, if a person has diarrhea. We can measure that. Not a pleasant task, but it has been done. We could do that, but a lot of times we're still not able to get a definite amount of fluid loss with diarrhea. But we realize it can cause some great fluid loss. So any patient who's got severe diarrhea, we watch for them to have this. So we're really going to monitor their intake and output. Your body needs essentially between 400 and 600 cc's for waste removal. Just to do its usual processes through the kidneys and through the colon. Yes, ma'am.
That's what I was going to ask. What is waste?
Mm-hmm.
Twisting your
It's just simply what it takes the body to do to go through the excretion process itself.
It was a very painful
BM is
process.
feces. Bowel movement.
The kidneys up there was really the only
They
thing
are
that's not included.
my clutch no longer.
Kidneys are the only
Bring
thing
them down.
that we can measure, because we can measure urinary output. All of these others, we really cannot get a true estimate of how much is being lost. We just have to kind of use these figures as a rule of thumb. But remember, what is the normal requirement for urinary output per hour? What's the minimum urinary output per hour?
I don't have a target.
30 cc's an hour is minimum urinary output. Okay? So in your spare time, you can multiply 30 by 24 hours and get what should be close to that 1,500 cc's a day.
I need a target. I need a target.
All play
I need to get closer.
start back with hyponatremia. Hyponatremia has several different causes, but what we see in the end result Hello, and welcome to Fluid and Electrolytes Part 2. Today we're going to be discussing the role of the hypothalamus and the adrenal cortex in the regulation of fluid within the body system.
Strength of the earth, hear my
The
call.
hypothalamus plays
Shield
several
them in this
important
dark
roles in the
hour.
regulation of
The
fluid.
last defender
The first of which
Azeroth.
is the fact that it is our thirst center. It responds to changes in the osmolality or the concentration of particles within the blood or the serum. If the body responds to the thirst
Our power
impulse,
now
then of
resides
course
within the dragon
fluid
soul.
regulation goes back to
Our
its normal
fate
routine.
lies with you, Importer.
If we don't respond to the thirst, then our body will have to incur some
I
other
will
processes
not fail
that will
you.
allow it to
I
shift
will not
fluid
fail
so that
this
it can
world.
maintain the hydration of the cells. Another important factor that the hypothalamus regulates is the production of ADH, or anti-diuretic hormone. And we'll discuss anti-diuretic hormone a little bit more in detail in just a moment. But first, let's just look at this very simplified pathway by which the hypothalamus incurs the thirst reflex. The hypothalamus picks up on the fact that there are more solutes or a greater concentration of the solutes within the circulating blood.
We can't let the destroyer get
It
away.
then induces the thirst response or reflex. If we mind that thirst reflex and we take in fluid, then that will balance everything out. It will decrease the osmolality or decrease the concentration of the particles within the serum, and all is fine. The problem that we may incur is when we ignore the thirst reflex.
I need to get closer.
Remember that our thirst reflex decreases with age. As we get older, we do not respond to thirst as quickly or as well. Also, medications. If our patient is under anesthesia or under narcotic medications, they may become lethargic. And the last thing on their minds is thirst. And so those patients are highly at risk for fluid volume deficits just because they are not able to respond to the thirst reflex. One other factor that thirst responds or is elicited in response to is hypotension, or a decrease in blood pressure. Most patients who become dehydrated also begin to develop low blood pressure. In fact, one of the primary assessments that we perform on patients who are admitted for dehydration are the orthostatic blood pressures, where we take the blood pressures sitting, lying, and standing. As the patient moves from position to position, if they are suffering from orthostatic hypotension, we will note sometimes drastic declines in their blood pressures. With the patients who have the decreased thirst reflex, one of the primary things that we can do as nurses to help them avoid becoming dehydrated is to offer them fluid. Every time we enter the room, offer the patient sips of water. It's something very simple, but it is something often overlooked because we're in a hurry to get on to other things in their care. And we tend to think of thirst as not the highest priority, but in some of our patients it can be the highest priority.
Concentrate everything on the armored drake.
The posterior pituitary gland also plays a role in fluid regulation. It is where ADH, or anti-diuretic hormone, is stored and released.
Looks like I'm doing this.
It's very important to make the distinction at this time that antidiuretic hormone affects water only, whether it's the holding on of water or the excretion of water. That is all that ADH generally affects, is water volume. We will talk later about some other releases of hormones that will affect electrolytes and water, but ADH will only affect water for the purposes of our lecture. ADH is released for various reasons. One of the first reasons it can be released is if the body picks up on that increased plasma osmolality. So first, if it picks up on this increase, first thing we're going to do is be thirsty. Then the next thing, if we don't
100%
answer that call for fluid, then our body is going to start releasing ADH, which will cause us to retain fluid. Examples of things that will cause an increase in osmolality: high glucose levels, and also an increase in urea levels. Remember, urea is the waste product. So you may see these things that will cause ADH to be released. What happens when ADH is released is that the kidneys just retain the water. The problems that can occur with that primarily are the fact that if we retain too much water, we can lead ourselves into renal failure, because the kidneys can become overwhelmed by this extra fluid that's being retained. So we have a very, very sensitive fluid system. It doesn't take much to cause changes, but it also doesn't take much to cause damage, especially to the kidneys. They're very sensitive to that increase in water. This is the simple diagram to follow for ADH release. We see an increase in plasma osmolality. Our thirst reflex is activated. If we don't answer that call, then ADH is released. ADH has its primary effects on the distal and collecting tubules of the kidneys. That is where it can reabsorb the water to prevent it from being excreted. And by retaining that water, it decreases plasma osmolality, which puts everything back to a normal routine. Another reason ADH can be released is a decrease in circulating volume. One of the primary causes of this might be a hemorrhage. The body tends to hold on or retain as much fluid as it can to compensate for this loss of fluid through the hemorrhage. If hemorrhages are severe enough, and other problems are also involved, maybe this is a major trauma victim after a car wreck, we can actually administer a synthetic ADH called pitressin or pitressin. And that is actually manufactured ADH, which can cause massive vasoconstriction. So you can imagine that we would not give this synthetic ADH for just your casual dehydration. This would be something very severe, severe hemorrhage, severe trauma, and things of that nature. Because remember, for every reaction, or every action, there's a reaction. We've all heard that. And that is the same is true with our body. Every little tweak that we do can change things within the body. Sometimes we have small changes, and sometimes we can have big changes. But there's always a reaction. So we have to be careful not to overreact and just complicate the situation further. Another reason ADH can be released is in relation to pain, especially if we have pain, say, following surgery, trauma, stress, and certain medications. Fluid retention occurs. If you've ever seen someone immediately after surgery, they tend to have that puffy look, and that's in relation to the trauma and the stress that their body has endured with the surgery. Anesthetics, remember, those decrease our level of consciousness They also cause our thirst reflex to be inhibited or increase our inability to answer to that thirst reflex. Cancer can cause retention. Many cancer patients suffer from pleural effusions. You may see ascites in the abdominal cavity. Pleural effusion is fluid within the chest cavity, not within the lung itself, but within the chest linings. And you may see that spacing occur because of that, because of cancer. And again, third spacing could be anywhere. It could be the pleural effusion, or it could be anywhere in the body in relation to all of these different things. Positive pressure breathing is another cause of ADH release. With positive pressure breathing, this is what we see with our patients who are on ventilators, where we are regulating the depth and rate of their respirations. Because we may be adjusting that rate and depth, we may increase the pressure that the lungs are picking up on, and in turn that means that there sometimes is a decrease in aortic return because of that pressure in the lungs. The body gets the wrong message in this case. It thinks because there's not as much aortic return that there's not as much volume circulating. And so it causes ADH to be released, and then that means that we retain fluid. So again, here's that cause and effect relationship. Every action that we induce can cause a reaction, sometimes big and sometimes small.
Before you is the cache of the aspects. Take from it what you
We may
will,
also see
for you
ADH
have
increased
earned the right.
in the syndrome of inappropriate ADH, or SIADH. This causes the water to be retained. In other words, the body is releasing too much ADH, so there's too much fluid retention. Several things can cause this. Generally, it's a brain issue, some type of injury to the brain, a tumor, or some other CNS disorder, but also some pulmonary diseases like TB can cause this. And again, this is just the excretion or release of too much ADH. And again, here's the simple kind of formula that goes with that. SIADH causes water retention, because remember, you're releasing too much ADH. When we retain the water, it decreases the plasma osmolality, but it may increase the urine osmolality or concentration, because remember, we're holding on to that water, so we're not having as much urinary output as we normally would. And so that's where you get that increase in urine osmolality. So they may be okay plasma-wise, but their urinary output begins to decrease. So these patients, we would definitely be doing monitored intake and outputs to make sure that they maintain urinary output at a minimum of 30 cc's an hour. We may also be giving them other medications to help treat this condition. ADH production can also decrease with some things. One of the primary things that will cause a decrease in ADH production is alcohol intake. That's ETOH, is alcohol abbreviation. If you have ever overindulged, the next day when you woke up, you had the symptoms of a hangover. Usually that's the dry cotton, feels like you got cotton in your mouth, headache, you just don't feel good, that sense of malaise. Your urinary output may be decreased at that time. What happens with alcohol is alcohol acts as a diuretic. It increases our output over our intake. And because of that, we get dehydrated. And the dehydration is where we see all those complaints of the hangover. It's all in relation to dehydration, as simple as that. Eventually, the output will decrease, because if you do not add fluid in, then of course there's no fluid out. So you may start off having a lot of urinary output, and then slowly that will ebb away. So it's very important that we tell our patients about this. You know, a lot of people really don't understand the mechanisms for hangovers and why they get all these signs and symptoms. Especially those, if you've ever known someone who got out on July 4th and they cut their grass. They decided they'd sit in the shade and they would have a beer. And then they wondered why the rest of the day they felt so bad. Well, it was because not only were they losing fluid out through the skin, they were also losing fluid out through the kidneys as well, because of course the alcohol intake would just increase their urinary output and decrease their fluid volume. So it just compounds the issue of dehydration. One other reason that can cause a decrease in ADH production is a head injury. Unfortunately, with head injuries, we really don't know what to expect. Every patient is different, and so we just have to look at this as a case-by-case basis. We may see an increase or a decrease with head injuries. Again, that is patient-specific, and we just have to monitor our patients very closely. Last but not least, ADH can be decreased with diabetes insipidus. You'll also see this abbreviated DI. This is where you have massive amounts of urinary output. You have the 3 P's that we generally associate with diabetes: polyuria, polydipsia, polyphagia. Increased urinary output, increased drinking or intake, increased eating or appetite. But they have all 3 of these P's, so they're drinking, they're eating, they're peeing, and they have weight loss. And so these patients again have to be monitored very closely, because again, with this shift in ADH production, they can dehydrate themselves very, very quickly. So we need to monitor them. Maybe we meant to have the IV pump set at 50 cc's and it got put on 100 cc's by mistake. Nobody noticed it for several hours. And this is our 90-year-old patient who was being treated for dehydration, and now we've kind of overhydrated him. Another cause may be we gave him tap water enemas. That's why it's really important, if we have soap suds enemas until clear, that we very cautiously give them over and over again. Because usually it takes more than one time to get a person clear, especially if you're getting them ready for a colonoscopy. And so we want to be really open to the fact that that could cause some fluid shifting. Also, NG suctioning or irrigation may cause some changes as well. Anything that causes a problem with excretion or a backup of fluid. So if we have someone who has renal disease, of course then we know the kidneys are not fully functioning, they can have a backup of fluid or retention. We also know patients who have heart failure, especially if it's congestive heart failure or CHF, we know they have an overload of fluid also. Adrenal disease, because it can change that aldosterone, ADH, you can start to have problems with those factors. Liver disease, and then cortisone treatment. If you've ever seen someone who's had to take prednisone for long periods of time, they begin to get that moon phase, softening of the features and swelling, and so that may also cause some issues at hand. Edema is one of the primary signs and symptoms of fluid volume excess. Remember, you can have edema or that plasma to interstitial fluid shift when you have an increase in capillary hydrostatic pressure or you have a decrease in plasma oncotic pressure. So remember that fluid, once it's pushed out into the interstitial areas,